I think laser ablation does offer certain advantages over open surgery for deep targets in the brain. So I think we will continue to see an expanded role and improvements with patient selection and targeting. But there's obviously an interest and need for therapies that don't rely on tissue destruction, particularly if the epileptogenic zone is large or overlaps with critical or eloquent areas of the brain. So this is where neuromodulation is really growing in popularity because it promises to treat seizures without permanently removing or ablating any part of the brain. I should caution that none of the current neuromodulation therapies have yet been shown to be as effective as surgical removal of the epileptogenic zone, if that is an option. They typically reduce seizure frequency and only rarely offer seizure freedom. But when resection or ablation can't be done safely, or if the patient declines a tissue-destructive procedure, then neuromodulation is an excellent option. So there's currently 3 different approaches to neuromodulation. Responsive neurostimulation, or RNS, targets up to 2 foci anywhere in the brain and provides closed-loop stimulation in response to seizure detection. This is currently approved for adults with up to 2 foci of focal epilepsy, but there are trials in the works for adolescents and also for idiopathic generalized epilepsy. The second approach is deep brain stimulation, or DBS. And this targets the anterior nucleus of the thalamus and provides continuous or open loop stimulation to modulate broader seizure networks. This is also for patients with focal epilepsy, but may be particularly useful for patients with multifocal or large epileptogenic zones. And then third, of course, vagus nerve stimulation, or VNS, has been around for many years and remains an option as well for neuromodulation without having to put anything into the brain at all. But I should say that the lines are blurring between these different approaches. In the research setting, we're seeing responsive neurostimulation, RNS, used to target various deep thalamic nuclei, and DBS, deep brain stimulation, being used in adaptive closed-loop fashion and to target the hippocampus. So there's still lots to be learned about the data that these devices are collecting, and the most effective stimulation parameters is something that we need to work out over time. But what is, I think, most unique about neuromodulation compared to resection or ablation is that we're actually seeing, with that learning over time, we're actually seeing some improvement in the effects over time. And this may be due to improved programming, or it may be due to the long-term effects of neuromodulation on the brain. And that's something that we are still waiting to see. I would say lastly, the newest area to look out for is focused ultrasound. And this includes high intensity focused ultrasound, where we can actually make small lesions deep in the brain, and also low intensity focused ultrasound being used to open the blood-brain barrier and deliver therapies to specific regions, or it can actually be used directly for neuromodulation. So it's a very exciting time with lots of new approaches that are already available and on the horizon.